It's 7 p.m. Central European Time. Good evening, everyone, and welcome back to another year of USOMI webinar series. If you suppose that we would skip January, in the last day of January, we did it. So welcome back. My name is Gianardan. I'm a neuroradiologist in Legnano near Milan, Italy, and I'm very happy to be with my friends and colleagues also for this year, trying to disseminate more knowledge regarding medical imaging informatics, artificial intelligence, and so on. As usual, in this webinar series, we will have now a lecture of about 20 minutes, and please don't forget to give a question in question and answer box. But now I would like to give the virtual microphone and podium to my partner in crime, Pinar Yilmaz. Pinar, the stage is yours.
Thank you very much, Gennaro. I'm very happy to introduce our speaker, Mélanie Champendal. We met during the last USOMI meeting last year. She will enlighten us on artificial intelligence in nuclear medicine, a first within our USOMI webinar series. Mélanie is a Swiss radiographer specializing in nuclear medicine and currently a member of the European Nuclear Medicine Committee. She works at the Nuclear Medicine Department at the Lausanne University Hospital and is currently pursuing a PhD at the University of Lausanne, focusing on the development of an explainable AI tool for PET-CT and image reconstruction. I'm very curious for this first within our USOMI series about nuclear medicine, and I would like to give the floor to Mélanie to enlighten us further. The floor is yours, Mélanie.
Thank you for this kind introduction and this opportunity to represent radiographers, and particularly the RFRS Nuclear Medicine Committee and the School of Health Science in Lausanne, ESAV. So, as said, I will speak about an overview of artificial intelligence in nuclear medicine. I'm sure you know that nuclear medicine uses radioactive elements for diagnosis and therapeutic purposes. Images are acquired with different machines as gamma camera, SPECT or PET alone, or combined with CT or MRI, which is called hybrid imaging, combining morphological images and functional images. The results of nuclear medicine examination can be separated into qualitative and quantitative results. By qualitative, we mean what do we see, for example, the size, the shape, or the localization of an abnormality, or the biodistribution of the radiotracer. And by quantitative, we mean what do we count when we are drawing a region of interest, and if it's present by, for example, the uptake of radiopharmaceutical, for example, for FDG PET-CT, the standard uptake value, the SUV, which represent a standardized way to express the concentration of glucoses in a specific tissue or region. So first we can see, as you know, this upward trend in the number of publications over the years, with a marked acceleration the last 8 years. And if we look at the paper of majoring, we can see for nuclear medicine PET and SPECT position in the modalities the most explored in 2020. And PET sits in the middle range of a 200 publication, while SPECT is in the lower end among the modalities listed. Nance and Hall dividing the typical medical imaging workflow into 4 steps: planning, scanning, reading, and reporting. And in their work, they gave example of tasks that could be performed, improved, or completely automated with AI intervention. Thus, AI algorithms can be used at each steps of a typical imaging workflow. And now we'll give you some example for each steps. And let's begin with the first one, the planning. I will speak about scheduling and exam preparation. And from one of the greatest challenges in the scheduling of medical imaging is the no-shows, which is particularly problematic in nuclear medicine because of tracer availability, decay, And in the study, the authors included more than 54,000 patients' appointments with scheduled examination, and they considered 16 data predictors, elements from the electronic medical record, like the no-show history, appointment-specific factors, and sociodemographic factors. And their model had a significant power to predict failure to attend a scheduled examination. This information can be used proactively to identify patients who would benefit from additional engagement through appointments reminders or other targeted interventions to avoid these no-shows. Often patient-related information given the time of referral is sparse, and extensive manual searching through large numbers of unstructured text documents by professionals is necessary to gather all the information that is needed for an optimal preparation and planning of the examinations. And structured reports that allow direct algorithm extraction of information are gaining in popularity and are essential, as you know. And for example, a relatively simple AI-based rules could automatically check for the presence of certain contraindications, such as allergies, or reduce unnecessary duplication of tests or exam by analyzing previous examination. So now, next step, I will speak about scanning, and with the three first: faster image acquisition, better image quality, and dose reduction. I will mainly speak about PET-CT, and there are some problems with this hybrid imaging modality. First of all, radiation, which is delivered by the CT and also by the radio tracer. Then the acquisition time, which is quite long in nuclear medicine, and it can be problematic for allergic patients, claustrophobic patients, children. And we should not forget that PET-CT is an environment that is quite close, and it can induce anxiety for patients. And for the PET MRI or PET only, there is also another problematic, because without CT, there isn't these new maps for attenuation correction. So some solutions were reported in the literature. Some studies try to develop algorithms or to decrease the injected dose or to decrease the acquisition time. And some other algorithms offer to use MR or PET images for the attenuation correction, and thus avoid the dose from the CT acquisition. So let's talk about reducing injected activity or reducing time per bed position. These reductions will adversely affect PET images with quality with a lower signal-to-noise ratio, as we can see in these images on the right. In A, you have the full dose injected activity, and the decrease in the activity injected until D, which is 200 times less activity injected. So to address this problem, many algorithms were proposed to improve the image quality and for denoising PET images. Subtle PET tool is an example for medical imaging enhancement that receive FDA clearance and CE mark approval. Subtle PET can be used or in order to reduce the acquisition time or to reduce the radio tracer dose. For the first option, when reducing acquisition time, they analyzed retrospectively 38 PET-CT and reconstructed them as if they were acquired with 30 seconds or with 60 seconds per bed position, as you can see. And here, the standard image acquired with 2 minutes that represents the ground truth. They compare the AI-enhanced images acquired with 1 minute or 30 seconds per bed position with the ground truth with the different metrics. And these preliminary results show that AI-enhanced 60 seconds per bed positions, bed acquisitions have good diagnostic image quality and are clinically feasible. For the second option, they analyzed prospectively PET MRI in 20 young patients. And here we can see low dose and deep learning enhanced PET image of a 14-year-old patient with Hodgkin lymphoma. In A, we have the fully activity injected of FDG in PET-CT that represent the ground truth. It shows hypermetabolic lymph nodes that are pointed with the arrows. And then B to F, they simulated PET images with decreasing injected dose from 75% to 6.25%. And we can see an increased noise and reduced contrast between the tumors and the liver from B to F. And then you have the H2L. We can see the AI enhanced image from 75 to 6.25% again. And they showed the reduced noise and improved contrast between the tumors and the livers compared to the non-deep learning augmented PET images. They did a qualitative and a quantitative assessment with different metrics and then conclude that enhanced of low dose scans with deep learning enables 50% dose reduction without changing response of pediatric lymphoma patients. We have just seen algorithms that solve some of the problems of acquisition time and dose delivered by the radioisotope, but we still haven't solved the problem of the radiation dose delivered by CT and the absence of these new maps in order to reconstruct PET images without CT in case of PET only or PET MRI. Here a study where the aim was to demonstrate the feasibility of the direct generation of attenuation correction FDG PET images from uncorrected image without using anatomical information, so without the CT. So they use as an input PET image without attenuation correction, as we can see in A. And with the help of deep learning, they reconstruct the PET image with attenuation correction, as you can see in B. Then they did a quantitative assessment by using the standard uptake value, the SUV. Here we can see on the right, and you can see the different bias maps in D between the reconstructed image in B and the ground truth in C. In blue, it's when the SUV is lower, and in red, when the SUV is higher in the reconstructed images. And they concluded that it was feasible, but sometimes breathing artifact could lead to a big difference in the SUV results. So now we'll speak about reading with developing the segmentation and quantification. The precise delineation of an organ or tumor from molecular images is mainly used in oncology PET imaging studies for quantitative analysis, targeting various aspects, including severity assessment, radiotherapy planning, volumetric quantification, or extraction of radiomic features. However, this is challenging due to the poor spatial resolution and high statistical noise of molecular imaging. And in current clinical practice, image segmentation is typically performed manually, which tends to be time-consuming and prone to inter-observer variability, as you know. Hybrid images means two sets of images. Currently, most of the segmentation algorithms used in hybrid images are applied only in one of the imaging sets, typically CT, image and not in the combined settings. However, the segmentation performance could be improved by using the information provided by both complementary imaging modalities, which is called co-segmentation. And challenges were observed by using this co-segmentation due to a mismatch problem visible when patients move between the acquisitions of both imaging sets, introducing artifacts such as breathing artifacts. An example in this article where they segmented the lung tumors in PET CT. In the PET segmentation, the central necrosis that we can see of the tumor was not taken in account, thus the segmentation failed. And then in the CT, the segmentations, the chest wall was included, thus again the segmentation failed. And the use of both modalities enhanced the segmentation performance due to not taking into account false positive voxels, as we said before, the necrosis or the chest wall. And I think I will speak about reading and reporting with detection, diagnosis, classification, staging, treatment response assessment, prognosis, and predictions. Let's begin with detection. Here an article about liver detection in gallium-68 dotted PET CT. They compared the human expert considered as the ground truth to the model prediction. They found true positive, false positive, and false negative, sure, with the models. But they conclude that the deep neural network can automatically detect hepatic lesions in gallium-68 dotted yet, but further improvement in detection performance are anticipated through ongoing enhancement in data annotations methods, increased also sample size, and advanced training methods. Now, an example for diagnosis and classification with an example for the diagnosis of Parkinson's disease using iodine 123 DaTscan Inspect. So they use data set with 50% normal and 50% of abnormal patients. They divided the set for training, validation, and testing, and the study has provided proof of concept for the use of AI in nuclear medicine images for the interpretation of DaTscan with 96.3% of sensitivity, but lower specificity. Now let's speak about treatment response assessment. And as you know, maybe FDG PET-CT is useful for staging and therapy response monitoring in lymphoma. A subjective interpretation of the scan based on the Deauville 5-point scale has been widely adopted. FDG uptake of each lesion is graded in relation to the reference region of the normal mediastinum or liver. And however, this inter-observer variability to the subjectivity of the interpretation is the limitation. So Sadiq and al. showed that an AI-based model can be trained to perform automated segmentation in CT images and then transfer the region of interest onto PET images to calculate the standard uptake value of the reference regions. 80 patients, 80 patients with lymphoma who had undergone a PET CT were included in this study, and the automated quantification of the reference level was comparable with manually segmented regions by experienced radiologists or nuclearists. Now, with treatment response assessment and prognosis prediction, Choi and al. Investigate in their retrospective study the predictive efficacy of PET MRI for the pathological response of advanced breast cancer to neoadjuvant chemotherapy. PET MRI parameters as standard uptake value, metabolic tumor volume, total lesion glycosis, and apparent diffusion coefficient were evaluated before and after the first NAC cycle in 56 Korean women with advanced breast cancer. And after 3 cycles of NAC, they added to these parameters the histopathologic response. The convolutional neural network using PET MRI data classified the patient into 2 classes, responders and non-responders. Work analysis was used to assess performance of the differentiating responders and non-responders. And the conclusion was PET MRI image deep learning model can predict pathological response to NAC in patients with advanced breast cancer. Now with prognosis and prediction, for example, prediction of coronary artery disease and associated risk of major cardiac events, Betancourt and al. Evaluated the added predictive value of combining clinical information and myocardial perfusion imaging to predict major adverse cardiac events. And clinical data were derived from patients' medical records. And they also, with the recorded risk records were hypertension, diabetes mellitus, dyslipidemia, smoking, and image history, a family history of premature clinical coronary artery disease, and presence of chest pain and type and shortness of breath were assessed by the stress testing during the myocardial perfusion imaging. They included a total of 2,600 consecutive patients during follow-up 3 years. The 239 patients had MACE, and MACE prediction were compared among machine learning versus machine learning combining imaging and clinical data and physician diagnosis. And MACE prediction was significantly higher for the model combining machine learning, imaging, and clinical data. Machine learning combined also had higher predictive accuracy compared with physician diagnosis. And machine learning could allow integration of clinical and imaging data for personalized MACE risk computations in patients undergoing SPECT myocardial perfusion imaging. All these applications are very encouraging and are beginning to be applied in clinical settings, but still many steps are needed. One of them is the implementations. It is crucial to facilitate the adoption of these models in clinical routines and have models with explanation, for example. In our recent scoping review, reported that XAI techniques are mainly applied in context of MRI and CT radiography for the analysis of lung and brain pathologies, but there is a lack of intentions to modalities such as PET-CT or SPECT-CT. And most of these XAI models were developed for classifications and prediction tasks. XAI currently does not sufficiently take into account end users such as physicians, but also radiographers who heavily depend on AI outcomes. A more interdisciplinary approach is needed, integrating diverse explanation to align with users' reasoning. And this includes recognizing user variability in context, backgrounds, knowledge level, and emphasizing the importance of tailoring explanation to individual perspectives and needs. So in conclusion, AI in nuclear medicine has shown potential in reducing radiation exposure, improving image quality, improving workflow, reducing waste, supporting image analysis, interpretation, and reporting, performing risk prediction and response assessment. Advancements in imaging and personalized medicine have generated a substantial volume of data, surpassing human capacity of review, as we know, and urgent data analysis support is crucial for clinical workflow to manage this influx. And this combined data set significantly enhance the possibility for individualized care. And as I said before, in order to help with clinical implementation, we need to develop explainability and include users in the interdisciplinary development of this model. This will lead to greater adoptions and improve user confidence. Thank you for listening.
Thank you so much, Mélanie, for your very effective presentation. I think we have a question, but before I would like to highlight one thing where AI could be useful about the no-show scheduling, the possibility to no-show, because it's a very relevant point. We in Italy have an important issue about the waiting list, and sometimes we have with an immense waiting list, we have a lot of no-show. So if also AI, also more than the general common good sense of the citizens could help us, it could be really useful for everyone. You noted that the importance of a no-show in the radio tracer, and for sure, but also regarding MRI or CT scans, it could be really useful. Pinar, do we have a question, right?
Yes, and I totally agree with what you say, Gennaro. We have the same problem in the Netherlands too, and I think especially after the COVID period, it was already increasing, of course, with asking a lot of exams by clinicians, but now it's even worse, I think. And if that's something we could help with AI, that would be amazing. We do have a question by Shupas Keruka, if I pronounce it correctly, about the AI algorithm for acquisition and reducing the activity. Is that according to the machine, or can it be used for all type of machines? Is the question.
Well, in fact, now it's not so much used at the moment as most of the AI models. So Yes, it should be. It needs external validations and helps that this AI algorithm will be useful for all types of machines and not only for one brand mark. So yes, we suffer, as in the others modalities and disciplines, that there are a lot of external validations and that it can be adapted to all this brand of machines.
Yeah, I can imagine that's I think the main thing for all of the new tools for the external validation, to get it working and implemented for the different softwares that we have.
Yeah, I am agree, and I think that is a very relevant topic. Do you have any other comments, Pinar?
No, I don't have any.
Well, so I think we are perfect on time, and we can go to the conclusion.
Can I have one question? Because within the nuclear medicine field, I'm wondering, because with AI in general, and of course the specialization that you are in, Mélanie, for the explainable part, what are the most, like you showed a great overview of the hot topics within your field. What are the first things that you think we could start implementing, or that are way ahead? Like I know that it has been talked before about, I mean, within radiology, for certain things, for acquisition time or for reducing dose, right? They're a bit further than within the nuclear medicine field. But I was wondering, what is your point of view in what is one of the first things that you think that is going to be implemented? Or
but you speak about explainable artificial intelligence or artificial intelligence in general?
I think both. I mean, AI in general is, of course, interesting, but explainable AI as a upcoming part, I mean, that's also one thing within our department that's getting more interest because of I mean, exploring the black box a bit as well, and getting answers in why we get those answers.
But you know, I'm a radiographer, and let's say that AI and XAI at the moment it's more for physicians part, like there for interpretation, diagnosis, classification, because it's mainly, I mean, it's the first things that AI is targeting is to help physicians, and a lot of research has done by physicians for physicians. So, well, this is sure, maybe it's the first that will be implemented, but I think it's really important to involve also radiographers, because they are the ones that are doing the quality of the data as well. You know, this technical part is really important, and a lot of skills. So I guess, and it's also the one that are the bridge between the algorithms and the patients. So to help these implementations to be more smooth, I think radiographers needs to be inside, and maybe more retentions in the reconstructed images is needed.
I think you are definitely one of the first steps, and I'm really grateful that you gave this answer as within my difficult question to simplify it. I think as a team, indeed, in the first steps, as what you mentioned, as the great workflow, and also acquiring the data that we need to improve these tools and to get to the explainable part in diagnosing and predicting is very important.
Yes, definitely. I totally agree. Also, because we are now also implementing AI directly on the machine, so with really better quality data, as you, Mélanie, said before. So to have a radiographer trained as and part of the flow is crucial. Even more because if we are talking about bad data, we can do not so much. And also, it's important, as highlighted on the presentation, that AI could intervene in a lot of part of the process of the execution, even during the scheduling. So
yes,
I think this is
sorry.
Yeah, sorry.
And
sorry.
as you say, the embedded solution, AI solutions, maybe sometimes are a bit hidden, and it's really important to develop these protocols, and the one that are able to develop the protocols and to adapt these embedded solutions to each machine is really radiographers or nuclear medicine technologists. So.
Yeah, sometimes for each radiologist.
They have their own protocols, right?
Well, I'm guilty as charged. So,
I'm just in training still, so no protocols yet.
So I think we can go in the conclusion. I say another time, thank you, Mélanie, for your wonderful presentation. I remember to all the participants today that we will meet everyone another time in Pisa, Italy. So I'm very happy another time in October. So please take a look on our social media channel when we will open the registration for our annual meeting. We had a lot of fun last year, a lot of scientific sessions. So please be involved.
Save the date, 11th and 12th of October this year.
Oh, you remember also the date?
Of course,
I was quite general about October.
After the successful meeting of last year, we hope to see you all the 11th and 12th of October this year in Pisa again. And Mélanie, thank you again for this great overview and enlightening us about nuclear medicine and AI. And Gennaro, thank you very much for being my partner in crime again. And I thank all of you for joining us, and hope to see you soon.
See you soon. Bye-bye.
Bye.